Thank you so much for taking the time to speak with me about COVID-19 and gynecologic cancers, as well as the efforts being made by the SGO COVID-19 task force. I'm thinking that maybe perhaps we could start with how you're seeing COVID-19 impact patients with gynecological cancers in practice, and what do we know so far?
Yeah, I mean, I think the biggest impact has been delay of surgeries and in some case delayed treatment after surgery. I think initially with the COVID-19 crisis, there was concern about maintaining resources, particularly personal protective equipment in some areas of the country, in some of the areas of the country, including ours, maintaining blood supplies. So I think the biggest one was really delaying surgeries to the point where we were taking certain cases and we're like, okay, we're comfortable with delaying this patient's surgery by, let's say, a month or two, versus perhaps a patient's cancer that couldn't delay. And I think that's what was causing a lot of consternation and concern for practitioners is who do you delay versus who you not delay. And like as an example, we had recommended that women with advanced ovarian cancer that more of these patients get chemotherapy up front rather than surgery up front. And so those are the kind of decisions that we were basically discussing. And we don't have any evidence base for this because a lot of it was just based on common sense. But contextually, it was based on what kind of resources were and were not available to various surgeons and health systems and hospitals and practices.
That makes sense. Um, so, have you specifically treated any patients who were also infected with COVID-19? And I'm kind of curious to know, I guess beyond surgery, how treatment's being modified for these patients, if at all, and maybe you could provide a few examples.
Yeah, I mean, I personally have not had any patients who are COVID-19 positive, but I've had some colleagues that were, and without question, it has certainly delayed their treatment, whether it's surgery and or chemotherapy. The big question is when do you retreat those patients? And for some practitioners, they've actually waited until the patient was COVID-19 negative on retesting, and if they were asymptomatic, they would go ahead and treat these patients. But the challenge for us is having a very careful conversation with the patient, make sure that they understand that they're definitely at a higher risk for morbidity as well as mortality. And I think that's a hard conversation to have because there's just so many unknowns. But but really, I think the biggest thing is just really delaying their treatment, and for some people, delaying that indefinitely to the point where everyone gets worried. Because even though you delay with the anticipation of restarting, your resource set at that time may not be such that you may not be able to restart that patient. So I think the biggest challenge for us over the last 6 weeks is that every day is different, like literally. And you wake up one day and you're told, you know what, you can't operate on anybody. Next day, you're told that you can't give chemo on X number of patients. And so I think it's that uncertainty that has been really stressful to both patients and providers alike.
It's a very good point. And I'm actually hearing mixed opinions kind of on when treatment should be restarted. I know some people are using tests and retesting just to check for that negative result. But then I'm also hearing that there's a lot of false negatives, right? So there's a lot of challenges that you're facing with that.
Right. And that's right. I mean, the problem is that the testing platforms, whether you look at the RNA testing, the viral testing versus the serology testing, they're not perfect tests, and you're going to deal with not only false negatives but false positives as well. But we have to do the best we can. But I think universally, I think people are recognizing that um, testing is going to be the norm pretty much in the country. They want to know whether or not the patient is COVID positive, even if they're asymptomatic going into surgery, because A, that has an impact on the patient's outcome, but B, it also affects the people who take care of that patient, particularly anesthesiology, because they're going to have to be fully dressed in PPE, and it was initially a way to manage and conserve PPE by knowing the patient's status. So I think if you talk to the larger health systems, including academic institutions in the country, they're almost all universally doing preoperative testing on these patients, which is, I think, one of the things that I know that you wanted to talk to me about.
Yes, definitely. So I'm thinking too, do you feel your institution has already experienced a peak in cases? What does the situation look like where you practice, and what are some of the measures that have been put into place to prevent further spread of the infection?
Yeah, it's interesting because there are various models that look at when the surge was going to occur, what resources you needed in terms of ventilators, hospital beds, et cetera. And the number of cases that we experienced in the state of Alabama was much less than what the models predicted, thankfully, right? And so it has not been as much of a resource burden as it could be. And so the things that we did is that we really pressed hard, and I mean, really kudos to our pathology department to really roll out testing. And I think that was really the big step, is to understand who was positive and who was not positive. Again, under the auspices of trying to preserve PPE, but also in terms of how to manage patients. We basically limited visitors to the hospital, and under sort of unusual compassionate circumstances, cancer is one of them, we would not allow people to have guests in the hospital. So you couldn't have a family member or a friend stay with you if you were being admitted. That's what's tragic about this, is that you had some really sick people in the hospital that were unrelated to COVID that were basically on their own. And that's, I think, kind of the tragic story. Same thing with the operating room. We really limited the number of guests. We basically universally masked people when they're in the hospital. We had stations at front doors that checked temperatures and asked for symptoms. So we had a lot of things in place, but I think the cornerstone is really testing. And because knowing the testing really puts you down a pathway where you're managed differently than a woman or a man who's testing negative. And so I think most people recognize the value of basically pre-procedural, preoperative testing for our patients.
Were you experiencing any testing shortages or anything like that, or were you okay with?
Yeah, no, we were fine. I think our biggest challenge was the turnaround time for testing. So we had a lot of facilities in the state or in the city that provided testing, but the turnaround time was 7 days. I mean, a lot can happen in 7 days. It's hard to act on that. And I think the biggest leap that our institution was made is to have testing back within a day. That was a huge deal. And now we have a testing platform that allows us to have tests back within 45 minutes. That has transformed how we manage patients. Like, particularly, I don't do obstetrics anymore, but it completely revolutionized how we manage obstetrical patients, right? In terms of knowing, because a lot of these patients are going to come in, they're active labor. So, I mean, I think those are the things that we did here. We've just started to roll out our serology testing, so now we know which patients, even which providers, have been exposed or not exposed, and obviously that has created great debate in terms of how to manage that patient population. But yeah, I mean, we put a lot of things in place here, and I think that in some ways we were ahead of the curve. The biggest thing that was limiting for us, to answer your question, was swabs. And so we were really concerned that, considering the amount of testing that is required in our health system, we probably didn't have the number of swabs to test all these people. So we could have had all the PCR reagents that we could have, but we don't have a way to test and collect. That's a bottleneck. And that's one of the concerns I have over the future, is how do we test not only providers and staff and patients, but contact tracing in the state? Like, how do you do that? Because I think swabs is a real limiting factor going forward. And so it's just something that we're going to have to watch out for.
It's a very good point. So why don't you tell me a little bit about the creation of the SGO COVID-19 task force? How did that come to be?
Yeah, so, when, back in the first half of March, it 19 was very formally as a pandemic by the World Health Organization. It was clear that this virus was going to be disruptive to many things. And so one of the things that we have every March is our annual meeting, and our annual meeting was going to be in Toronto, and we had been having discussions up to that point about whether we needed to cancel it altogether. And once we got past that hurdle of saying that we have to cancel this for the most obvious of reasons, then it exploded. Like, you saw the spike in Seattle. You started to see the spike in Italy. You saw what was happening in Wuhan, China. And so then all of a sudden we're like, whoa, we have a major problem, to the point where practitioners recognized that this was now going to affect their daily practice and how they managed patients. And so we got a lot of requests from our members saying, what do I do in this situation? What do I do in this situation? And so we decided to put a task force together that would look at various key components of how we manage GYN oncology and try to put out best evidence or best opinion guidance to really help our members, because otherwise people were just winging it, right? And I think what we had learned is that there are some great lessons that you can pick up from other people from other parts of the country that are in the smack in the middle of it, that you can then take on upon yourself. And so some best practices, and that's exactly what we did. We were basically putting out best practices that for our entire membership and sharing that. And it was really transformational for us, because we have never put out this much information in this short period of time ever in the history of our society. And it demonstrated, A, what we were capable of in such a short time frame, but B, the amount of volunteerism that people still wanted to contribute, even being slammed at work and worrying about their patients and their practices and their families. It's a really kind of a remarkable time. I think when we look back at it, we'll look back at it as like, wow, it's really amazing what we're truly capable of.
It's so exciting too. And I was checking it out on the website. I saw that surgical considerations for gynecologic oncologists during the pandemic were released. Maybe you could speak to some of those considerations, best practices that you included in there.
Yeah, I mean, it was amazing, because when so that came out in 2 parts. And in the first part, we, I think, had literally over 600 people sign up for that webinar, which for us is a huge number of people. And then the second part was really a follow-up on that. And so the main considerations are this. The main considerations are, and we talked about some of this, is the importance of preoperative COVID testing. And what concerns me is that there are probably large swaths of the country that don't have access to rapid testing or rapid-esque testing. And so that's going to be a real challenge. And in addition to testing, there are facilities that are doing CT scans of the chest to see whether or not there are radiologic changes that are consistent with COVID as well, preoperatively. The second thing is, the use of personal protective equipment in the operating room and how that's managed. That gets tied into testing as well. The third one, as we mentioned earlier, is what patients can be legitimately delayed and which patients cannot be legitimately delayed. And then the massive gray zone in between in terms of how you deal with that. And so, you talk about, if you have the resources, do you need to pull the trigger now? If you have an alternative therapy, can you do that? And it's, there are pockets where it's obvious, but there are big swaths of it where it's not obvious. And that's what that communique talks about. And then we also talk about that there is this putative risk of aerosolization of the virus. So patients who have laparoscopic procedures are at this theoretical risk of basically shedding virus at an increased rate than non-laparoscopic procedures. And I don't know how much you know about this, but it's all because of the gas that we put into the patient's abdomen, and we release that gas like a valve. And so there's been a lot of discussion about how you minimize that and how you control that. I mean, those are the main thematic things that we've been looking at in terms of surgery. But it's amazing. If you had asked me this question 2 weeks ago, my answer would have been somewhat different back then. It would have been more resource intensive than anything. And I think that we're starting to, knock on wood, emerge out of this. So I think that the discussion is a little bit different. But my concern is that we're not out of the woods. We're all worried about, now that states are lifting their restrictions, do we see a second wave? If we do see a second wave, how severe is that? And if we don't see a second wave and we see sort of baseline cases, how long does that get dragged out for, right? Because I think our biggest challenge, and for the people that listen to this, my greatest challenge is convincing patients to come back in, right? And I think that there is overwhelming fear and concern that patients don't want to come back in, and that's going to be a major barrier to providing care. Not to mention all those patients who have foregone their cancer screening in the last couple of months. That will drag on as well, and we might see an uptick in terms of invasive cancer cases. So it's multifactorial. I mean, this is going to be hard. I mean, we're not out of the woods, and I mean, there are reports that surveillance is going to need to go out as far as 2024, right? So this is not a 2020 summertime, springtime thing. I mean, I think we're going to be having this conversation well into 2021.
Thank you. And maybe could you preview some of the gynecologic oncology considerations that have been released overall? I saw that was a separate section.
Yeah, so the other separate section that we looked at also is what to do about chemotherapy and clinical trials. I think the nutshell is that there are several things you should look at. One is the chemotherapy that you're going to give to the patient curative, right? Because if it's going to be generally curative, then don't delay their treatment. That's really the general adage. Push them through even the area of COVID-19, because we recognize if you delay their therapy, you might be impinging or sacrificing their outcome. The second one is looking at their age. The third one is looking at how frail they are. So there are patients who have numerous comorbidities that are elderly, where perhaps treating them in COVID-19 might be worse. And then also looking at the degree or level of toxicity of the drugs that we give them, right? So I'll give you an example that's a unique challenge. I mean, so in our field, checkpoint therapy or immuno-oncology, drugs like pembrolizumab, Keytruda, or nivolumab, Opdivo, are playing a bigger role in how we manage patients. Well, one of the side effects of those drugs is pneumonitis, which is basically inflammation of the lungs. Well, that pneumonitis looks very similar to COVID-19 infection, right? So how do you balance that? And so I think those are the biggest challenges that we have, is trying to stratify, what are you trying to accomplish here, and who are you really treating? And is the patient really probably too elderly or too sick to be treated safely, and you might have to consider delaying them. So that's the kind of the rubric that we're trying to get providers to think about, not just the simple yes or no, but the stepwise process in terms of making that decision. I think the biggest challenge for us also has been the fact that this has completely shut down our clinical trial operations. And so it's been really challenging to put patients on clinical trials, and because we don't have the staff, like either staff are not in, or they're at home, or they're sick. And so for many sites, clinical trials have come to a grinding halt. And for many of these patients, clinical trials are often their best option, right? And so now we're trying to figure out how to reemerge out of that and sort of get our clinical trials back on track. So I think those, in a nutshell, those are the things that we have kind of espoused and learned, and some of the advice that we passed on.
Thank you for sharing that. What would you say are some of the other resources that are available for patients and providers alike through this task force?
Well, I mean, I think that, I mean, not surprisingly, SGO is not the only one that has come out and put out a lot of guidance. I mean, I think so it's interesting. So gynecologic oncology kind of sits in this women's health space, because we want to take care of women, and also this oncology space. And so we kind of tap into these two areas. So on the women's health side, I think that, the American College of OBGYN, the CDC, the American Society of Gynecological Laparoscopists, the Society of Gynecologic Surgeons, they've put out some really good stuff in terms of guidance, in terms of helping providers. On the oncology side, the American College of Surgeons, the American Society of Clinical Oncology, our society, the FDA, they've all put some really good guidance out there as well. And then for our patients, and this is interesting because, we put a lot of stuff for our providers, but we don't want to forget about patients, because patients need a clearinghouse for information. The Foundation for Women's Cancer has put out some really good stuff in terms of basic guidance, and you're going to be seeing some more really cool stuff coming from the foundation, hopefully this week, actually, on almost patients think about now that we're coming out of the crisis. So those are all really, really good resources, but not surprisingly, they've all put out a ton of information, basically.
Great. So what do you feel is most needed to quell this pandemic?
I think what's most needed is still having respect for things like social distancing, and wearing a mask publicly, maybe for the next several months, if your provider thinks it's reasonable, embracing a telemedicine platform. Also asking, whether or not do I absolutely need to have this procedure or test done in the era of COVID. Also being patient and recognizing that everyone is super stressed out under these circumstances. I think this is not a time for people to lose their cool, because I think that patients, providers, administration staff alike, and families were under an inordinate amount of pressure. And I think there just needs to be an understanding. But to recognize that this is not like flipping in an on and off switch. We talk about flattening this curve. We may have flattened it. Remember, the curve, when you flatten a curve, it pushes the curve out. And as a consequence, I mean, we may be dealing with these issues for many months going forward. But again, just to recognize that everyone is doing their best. More often than not, we don't have answers to everything that we do, and that we're trying to do things based on common sense, compassion, care, patience. And, eventually we'll get through this. But I just think that this is, for me and you, probably the most transformative thing that we will go through in our lifetimes, right? It's our version of the Great Depression. It's our version of the 1918 Spanish flu. I mean, I don't think medicine, and I don't mean to sound negative or pessimistic. I don't think medicine will ever be the same after this. I think that we will wake up and reprioritize what's really important for the United States for our patients. And I mean that in a good way, but I don't think we can ever get back to business the way it was pre-COVID, right? And the most important thing is, I think many of us have taken things for granted that we shouldn't have been taken for granted. And I think for that generation that lived in the Great Depression, you could tell that they lived in the Great Depression. They look at life very differently. I think this generation is going to look at life very differently. And I'm hoping that we will embrace what we have and not be so critical and not take things for granted. So I do think there's positives to come out of this, but it's a long answer to your question. But I think a lot of it is recognizing that we're in it for the long haul. So hopefully the brunt of it, the worst of it is done, but it's not done.
Very well said. I guess, was there anything else that you wanted to add that maybe I didn't ask you?
Yeah, just to, particularly for our patients, I think that I think that people should learn to be skeptical. One thing that concerns me is that there's no quick fix to this problem. And I've had patients come up to me asking whether X, Y, and Z will get rid of their COVID or protect them. If it sounds too good to be true, it is, right? And I just feel like with all of our access to social media and the internet, I just think that we have to be skeptical and realize that this is just going to take time and patience for us to deal with that. And again, lastly, just to be patient with our providers. I think that message is being passed, but this is really stressful. I mean, people when you're dealing with the unknown, it's hard for everybody. And providers are trying to protect their families as well. So they have to look at it from their lens, and we have to look at it from the lens of our patients.
Thank you so much, Dr. Ho. That's all I had for you today.
Good. I hope that was helpful to you. I don't know if that was or not.
It was so well said, and I can't wait for our audience to learn more about the task force and everything that's happening at SGO. Thank you so much.
And if you have questions along the way about other work product things, feel free to reach out to me for sure. So.
Fantastic. Thank you. Have a wonderful day, and please try to stay safe.